You can help me with that. Let's start with FFT. Functional family therapy is interesting. It is a systematic, as you heard in the introduction, it is a practical, it is a pragmatic model. This is not a model with undefined, broad, general sorts of theoretical things. There is a theory to it. Of course, there needs to be a theoretical foundation, but it is also enormously practical. At the same time, it is enormously client-centered. I work with many, many families. The Astrid, who is our international clinical director, who, by the way, is much better at FFT than I am. Speak to her if you have questions. She has a way of taking the theory of FFT and matching it to clients so that it becomes a model that wraps around the client rather than a model that forces the client into a particular way of being. So that's one of the unique things about this model. Secondly, it is research-based, as I said, and it is both a prevention and an intervention tool, meaning that FFT, as I'll show you, is used in settings where it is used to prevent kids from going further into the mental health center system, or used to prevent youth and families from going further into the justice system or other places. On the other hand, for those kids that are really in trouble, FFT is frequently used as what we call the last stop, meaning this is the last chance to keep them at home, this is the last chance to keep them out of jail, this is the last chance to keep them out of the hospital. So what's unique about FFT is it can be both. It can prevent and it can treat. What's interesting about FFT, we try to focus on adolescents mostly. I'll explain why that is as we move along, and adolescents in these two ways. But I also want to suggest to you we have a variation and an adaptation for children. We have an adaptation actually for young adults. Because one of the things that we're discovering in the United States is this. No longer do kids leave their home at 18 when they go to the university or when they leave and get a job. They stay at home a very long time. And so young adults that are in the justice system and the mental health system, we're finding that FFT, our current research studies are finding that FFT is equally successful with those young adults. So it means we're using it as a couple therapy intervention often. And what's interesting is FFT is very short term. It does not, you do not have to see a family and a youth a long time for you to be able to help them. In fact, what's interesting is most of the research data would suggest this. It would suggest shorter is better. Because guess what? The longer you're with the family, you wear out your welcome. They get used to you and they stop listening. You get used to them and you don't hear anymore. So there is some magic number of sessions in there where you have the ability to have an impact. And FFT capitalizes on those. And the way that it does is FFT begins intervention in the first minute of the session. We don't do long assessments. We don't do long listening. We intervene and listen and assess simultaneously rather than sequentially. And from an FFT perspective, it's made up of a number of things. We have a foundation to it, right? There's a theoretical structure to FFT, and our structure is this. It is a multi-systemic, and by the way, if these things are not in your slides, don't worry. It is a multi-systemic approach. We start with a family, but we certainly deal with schools and other people. But it is also a relational approach. The basic unit of analysis for us is the pattern between people. As Gregory Bateson said a very, very long time ago, the father of actual family therapy, he said that the calculus of therapy is 1 + 1 = 3. Now, we've all taken math well enough to know the curiosity in that formula. You've got person A, you've got person B, and you have the space between them, and that space is the relationship between them, and it is that relationship that gives meaning and context to the behaviors that they have. Now, FFT also has a lot of the common factors of other models. You'll see that it is not totally unique. It also has a very unique focus. We're much less interested in how people got here, and we're much more interested in how they work. So the pathway they use to get to today is less important to us than how they're functioning today, which comes from another family therapy principle, systems principle, called equifinality. There are many roads to the same end. Equifinality. That means that you can spend all your therapeutic time looking for the road, or you can forget about that and you can just look to see where they ended up. So using those core systemic principles is what we're doing, and we're looking at functions. And lastly, FFT is built on a specific change process. For example, we're start at the beginning. What does it take to get someone into the room and stay in the room with us? Secondly, what does it take to get them motivated? Now, I don't mean motivated to come to your office. I mean motivated to change. Those are different motivations. And then what do you do after that? And what do you do after that? So we have a very systematic change model that makes up FFT, and it's reflected in our phases, the 3 phases of the model. Now, the goal of FFT is this. The goal of FFT is to be family focused while at the same time being clinically specific, while at the same time being functionally oriented. That is a tall order, folks, a very tall order. It is not an easy therapy. FFT, as you'll see, is extraordinarily simple and amazingly complex. Slow down. I can do that. This will be hard for me, but I can do that. Thank you. See, that's the kind of help I need. Sometimes I just start. You know, I do workshops all over, and when people are so kind, I just start, and then suddenly it's 5 o'clock, and they're still working on the morning thing I said. So this is really helpful. Now, the other thing that we're really interested in doing in FFT, it's built on cultural competence. You know, it's really interesting to me how many therapies are culturally bound. You must notice that. You must read these Western theoretical models and look at them and go, what? How does that work here? Now, the one unique thing about FFT is that it seems to work across cultures. And I think there's a reason for that. I can't tell you the scientific reason, but I think the reason is because we focus on relationships. We don't care how people function. We just want to know, we want to look at the inside of how they do it. We're focused on changing how they function. Our goal is, we don't have a prototype of how to be a good parent. We do have a prototype of how we can work within relationships to help them get to where they want to go. So we're process focused, not content focused. And that's what allows us to cross cultures and be congruent with those. We work in a lot of places. We work in mental health centers, we work in probation and legal systems, we work in child welfare, we work in social work settings, we work in forensic psychiatric institutions, we work in outpatient therapies, FFT is done in homes. It is not the modality and it is not the system that determines what's good therapy. Now, let's take a step forward, a step kind of to the foundation. That's a bit about FFT, and that's why you're here. But there's, as I said earlier, there's a little bit of context that's important to understand. And I'm going to fairly quickly, but not too quickly, I know, work hard to try to give you this overview of problems of youth. And some of these things you know, but they help set the context. First of all, clinical problems that we deal with. We deal with school problems. We deal with drug problems. We deal with conduct problems. We deal in many ways with mental health problems. And typically, those mental health problems are in the category of externalizing disorders. Now, the problem with that category is we deal with a lot of kids that behave badly. But guess what? Every one of them has very complicated things going on the inside. We almost never deal with a youth who just has a behavior problem. These youth also, some are depressed, some are anxious, some have ADHD, some are suicidal. The list goes on and on and on. And what's important for the context to understand FFT is an American saying that I don't know if it fits here, but don't make sure that you look beyond the cover of a book. There's more to the book than the cover. And that's the point here. There's more to the youth behavior than they're acting out. And so by doing that, we're able to deal with a lot of different things. So let's talk for about 10 minutes. And again, I'm going to do this a little bit quickly because this is less important than the FFT part. So if I skip over a few things, don't worry, you can always go back and look. But this is more for context than it is for anything else. Let's try to look at what these problems are, because it's really important to look beyond the cover of the book, but to look what's inside it. And to do that, we have to have a little bit of information about what that is. So, you know what's interesting is that it's surprisingly difficult to understand what goes on. It is surprisingly difficult to categorize youth. In fact, quite honestly, if you see a screaming, yelling, upset boy, it is very difficult to know if that's a conduct disorder, if that is a mental health problem, if that is something else. It's really hard to see, and our classification systems don't always do a good job of that. Do you use the DSM here or the ICD? Okay, use both. So those are wonderful systems, but they don't help very frequently with treatment. They help very much with classifying, but they don't really tell you how to help. So it's an interesting thing to make sure you don't get lost in the cover of the book. Don't get lost in the categorization. And so for us, what's important, if you're going to develop good treatments, you have to have an understanding of what goes on with the youth that you're trying to help. Now, quite honestly, many of the problems that we get sent, of the kids that get sent to us, are normal. They're very normal. I mean, they're normal in different cultures. They may not be normal here, but I have to say, in our culture, if we have an adolescent who's fighting us, oppositional and difficult, if you're not their parent, you can see that as an important developmental step. If you're their parent, it's an entirely different story. Then it's a problem. So it's important to remember that some of these things are really very normal. Now in this culture, I'm sure that youth are very clear to make sure to be respectful. Youth are very clear to make sure that, that they follow, everybody's laughing, but that they're very sure that it's important to follow what their parents say, etc. But I can tell you that probably somewhere, many of the problems are fairly normal. Now that's difficult for the parents that come in, right? Because for them, they feel like it's a problem. Other problems are not normal. And they're not normal because they lead to some very, very difficult things. And they cause great problems. And the difficulty is telling the difference. So let's look. First, outside problems. This is the way we typically in the field categorize. Externalizing problems. Well, hyperactivity, aggression, psychiatric categories. The kids that we deal with in the juvenile justice system that have been caught by the law, they did something that someone said they shouldn't have. Categorized as externalizing problems. Now, the funny thing is that this set of problems is the most common referral for any mental health professional in the United States. Whether it's a social worker, it's a psychiatrist, it's a psychologist, or a marriage and family therapist. The most common referral for treatment is an acting out youth. More common than depression, more common than anxiety, more common than serious mental health issues. Acting out youth have flooded our mental health and juvenile justice system. Now we have to take a look and try to understand what those youth are about. The research says this. There are two pathways to being and acting out youth. One pathway is what we call an early onset or an early onset trajectory. This is a category of youth that at 4, 3, 4, 5 years old are difficult to deal with even at that point. And there are some of those. These problems begin early and they're very difficult. You know what's interesting? If we just don't make it worse, almost all of them get better. Who knows? Nobody is clear where this comes from, whether it's biological, maybe it's temperament. We don't really understand what it is. It's clearly not the psychoanalytic thing that it's because of their mother. That's not what it is. But we don't totally understand it. But if we could just not make it worse, they'd get better. Which provides an opening for treatment. Early onset kids, the best treatments you can give are to try to keep the family from making it worse. And that's not an easy thing, because if you're a parent of a youth like this, a child, this is difficult. This is not easy. We can't just say to them, be patient, it'll get better, because they have to live with them every single day. Now, of these, the second category are a late onset. This is the adolescent. This is an entirely different category of youth. I don't know if you remember being an adolescent. I do. When I don't even know when it happened, but suddenly my interest turned from inside the family to outside the family. Suddenly I was fascinated with my peers. Suddenly I was much more interested in what people at school thought of me than what my parents thought of me. Suddenly all the interesting things that were happening in my world became of great interest to me. And that changes a family. Because at that point, parents can no longer force kids to do what they want them to do, because now the attention is on the outside, not just on the inside. And this late onset, or in the adolescent years when they become more social, this is a different kind of problem. And most of these youth don't get better on their own. Most of these youth go on without help to become serious offenders, to have serious mental health problems, and to have very, very difficult issues. Now what's curious is our field is frequently more interested in catching things early. We're more focused on the early onset than the late onset. And maybe that's not the particular attention to pay. Now, in that category of externalizing behaviors, again, maybe not totally fitting you, we have a terrible situation with youth violence. You see it on television all the time. I'm sure it's one of those things you think of America, right? Everybody here has heard of the Columbine shootings. Everyone here has heard of the recent shooting 10 miles away from Columbine, where the young adult man went into the movie theater and murdered and massacred people. 10 miles away from where Columbine happened more than a decade ago. We have had scores of issues where kids in schools are violent. It is a tremendously serious problem, and it is going up. Now, the interesting thing is, despite the fact that more recently it seems to have leveled off, if you ask the youth, instead of look at official statistics, the problems are way worse than we would ever know. It isn't just violence. Drug use in the United States and in most countries is rampant with youth. I understand less so here, and that's a good thing. You're lucky. But in the United States, most kids, by the time they graduate from high school, have experimented with illegal drugs. And many of those have experimented to the degree that they have become serious, serious problems. And guess what? We spend an enormous amount of money, billions of dollars, on helping youth with drug problems. And it has only gotten worse, because as we've sorted through our issues with cannabis and other things, these designer drugs have risen. And if you've been watching the news, there are chemists out there that are able to every day produce a new drug. Recently, it's bath salts. I don't know if you've had trouble with that, but in the United States, there's a category of drugs called bath salts. I mean, I thought that meant you got in a bath and you and it was a wonderful experience. No, I think it's terrifying, and it's really awful. And you can buy them on the corner store in the United States because they can't keep up with the variations. So guess what? 60% of the kids that go into drug treatments in the United States are repeaters. Our treatments for drug abuse are abysmally bad. They're terribly ineffective in the United States. Part of that is for a couple reasons that I'll tell later. The cost, the latest estimate, $100 billion a year. We could really use that to feed poor people and to house poor people. We're using it to try to combat youth drug use. Mental health problems, we think that about 22% of the adolescents in the United States have a diagnosable mental health problem. That's scary. That is really, really scary. And guess what? In the United States, it is the juvenile justice system that has become the major provider of mental health treatment. Kids don't get help until they get arrested. And if they get arrested in a place that has good treatment, they're lucky. If they don't, they're not so lucky. And the economic impact is gigantic. That's externalizing problems. Now let's take the other end of the spectrum, which are internalizing problems. And by the way, when I talked about substance abuse, let me include a category of things that I think probably fits here, which is substance use problems are very similar to things like gaming addiction. Addiction to Xbox and addiction to games, those are addiction-oriented behaviors. Sexual addictions, pornography addictions on the internet, those things, they fall into the same category. Now, when it comes to internalizing problems, these kids are much less likely to be referred until they get to be suicidal, quite honestly, because they're the quiet youth in the back of the class. And you know what happens in school? It is the loud one that gets the attention, the quiet one doesn't. These are the quiet, suffering kids that have depression and some anxiety. Now the ADHD kids, that's different. They get a lot of attention because that sort of is a combination of things. They're easily overlooked, and what is very, very important to remember, these internalizing problems are not individual problems. They fit within context. They change a school. They change a family. They result in suicide frequently. These internalizing problems are not just individual, they're also family-oriented. Sorry, I pushed too many buttons. Now, given all of that, here's the issue. Whether it is externalizing or internalizing, it almost does not matter. Because guess what? These behaviors affect all of us. If you're a parent, it affects you. If your sibling your brother or sister has one of these problems, guess what? It's going to affect you. It affects the extended family. It changes the community. I have a stepdaughter who when I lived in Las Vegas, she went to school at a very nice school, very nice neighborhood. By the way, there are neighborhoods in Las Vegas, not just casinos. I know the translation's got a little delay, so I'm just learning to wait for the reaction to see if the joke works. And I lived in a house, I didn't live in a casino. And you know, when she went to school every day, she had to go through a metal detector. Every day she had to go through a metal detector. Why? Because somebody brought a gun and they had violence in the school. So one youth changes the culture of her school. And that's how this works. It does not these problems are family, they are community, they are our cultural problems, not just individual problems. And the cost is gigantic. The cost is one that we all bear. And so it has an impact on all of us, these particular things. Oh, I'm not sure. Every once in a while, my slides want to do something on their own. And this was one of those times. I'm into autonomy, and I really support their individuality, but every once in a while it doesn't help. My point, These are all family problems. It doesn't really make a difference which one they are. What makes a difference is as a field, as a profession, whether you're a counselor, whether you're a family therapist, whether you're a psychologist, whether you're a social worker, what makes the what's important here is to remember, don't get confused. They may be problems done by a person or experienced by a person, but they are problems felt by everyone around them. They are family problems. And guess what? As a result, they require family-based solutions, not just individually based solutions. I have colleagues that don't know how to do family therapy, and so they do individual therapy. I have colleagues that believe that it's easier to talk with the youth one-on-one, and it is easier. The question is it more effective? Now, a little more independence from my slides happening here. Oh no, okay, I know what this is. Okay, we're going to switch, and I want to show you one of these young people.
Try something different. It's pretty much, what we can keep coming and we can keep trying, and pretty much this is the chance you have, Ted, to maybe make it a little bit better at home.
What makes this different from any of the other 600 that I've been to? You think I ain't ever talked to people like you before?
It isn't different yet. What she's saying is we're making it different.
Be how?
Why won't you just want to keep
Because I don't want somebody to help me. I don't want you. I don't want them. I don't want you. I don't want you. I want you to shut up and leave me alone. All of you. Shut up and leave me alone.
And then what's going to happen to you?
I'm going to do it myself. I don't want anything. I will take care of myself. Stop worrying about me. Stop.
Take care of yourself.
See, you don't know that.
How
You're
you take care of
stupid.
yourself?
You're stupid. You're stupid. You don't know me. You don't know me. You don't know. None of you people fucking know me. And you just fucking bother me. You don't leave me alone. You don't let me do anything. You just, stop trying to help me. Stop. Stop. Stop.
And you wonder why people don't want to be family therapists. Is it an internalizing problem? Is it an externalizing problem? What is it? Well, it's just scary if you're the family therapist. And so on the inside, what we have to do is that we have to try to figure out, no wonder it's difficult to try to figure out these behaviors. Now this young man, I may not learn a lot of Korean when I'm here, but this one I'm going to get before I'm done, because I think we'll see it a lot more times, unfortunately. Okay, we're on the right track now, I think. Good enough, at least. We're not on the right track. So let's see. Hey, the weather's really nice here. That's a joke. I'm sure glad that these guys are here, because I would not have a clue what to do. Okay, this is good. I think we're on. I think we're all set. Yes. Okay. So, well, we'll get it. Just one. Hey, by the way, who has a question? Maybe that's a good thing we can do. Yeah, why don't we do this? Why don't we, given that we've been talking for a while, why don't we go ahead and take our short break now? We'll fix these problems by the time we come back. And let me ask that if you have questions, think about them in the break and come back and be sure to ask. So let's take our break now, okay? Is that good? One of the things that we like to do when we go places is I can tell you about FFT, but one of the nice things is that we think we can teach it and we think we can talk about it because we regularly do FFT. I see families every week. Astrid sees families. Astrid supervises families. And in our training of FFT, It's not a theoretical training, it's a theoretical training plus a practical training. So I'll talk tomorrow afternoon a little bit about how we do our training, but one of the things we do when we work with a team that's learning FFT is that we have each clinician every year, 5 or 6 times, bring a family in, and we observe them working with the family, and we help them at the time, rather than later, rather than after, but at the time. And really frequently when I do talks like this, groups will want us to do a live session, and that's wonderful. Because the truth is, if I can talk about it, that's great. But if I can't do it, that's not so convincing. So it would be really nice to be able to do both. So if some of you brave souls would like to work out, as long as you don't hurt me, meaning don't be like this boy that you saw, or be whatever way you'd like. But if you would like to organize becoming a family, that would be terrific. And tomorrow afternoon we could do that. The thing that will be a little difficult along the way is, along this line, we like to show what we do, not talk about what we do. So you saw a little bit of the video of the young man. Before the day is over today, you're going to see what I do with him. I didn't show it to you just so that you could see him yelling. I showed it to you so you could get an idea of the difficulty of the youth. So before today's over, I have to show you how we help fix that. And we don't do anything that will fix his problems immediately, but what we do is this young man is unlikely to ever come back to treatment. So what we do is our first phase, which is to get him to come in, and I'll show you that before the day's over so that you can see. That will be difficult for the translators because it's hard enough for them to keep up with me, but to keep up when there are many people speaking at the same time, it's very hard. And I went and met them earlier, and they're very nice, and I think they're doing an exceptionally good job with my weird American jokes and my fast speaking. So. I want to do one more thing before we take a break, and we're going to go. There's been another small change in the schedule you may have heard, where we will do lunch not at 1 but at 12:40. So that means we will go now until 12:40. We won't take a break. But around 12:30, I'm going to stop talking and ask for your questions. So you can already prepare for what your questions might be for then, and maybe even a little earlier. So we're going to adjust the schedule around our delinquent computer and around our earlier lunch. I've also been asked to go slower. I'll work on it. I don't know how successful I'll be. One more piece of context, and this is one more step we need to do as the foundation for functional family therapy. And that is this notion of evidence-based approaches. As I said earlier in my brief introduction, evidence-based approaches are relatively new to psychology. They're not new to medicine. They're not new to other professions, but they're new to us. And they're extraordinarily controversial in the United States. They're very controversial in the United Kingdom. And I'll try to see if I can't help you understand why some of those things are controversial, so that we can then, when I begin to show you evidence about FFT, that we may be able to understand sort of how we've gotten around that. So in this next section, I want to talk about evidence-based treatments. Now this is relevant to FFT because FFT is an evidence-based treatment, and so these are many of the concerns that people have about FFT. They're the same concerns as other evidence-based psychological approaches. Now, what's important, as I said before our break, I talked to you about two kinds of problems. Generally, we have youth that act out, we have youth that struggle inside, and my point is that while we classify them in those ways, it is not always so helpful or easy to sort it out. Most of the youth we deal with have both. If you're acting out, there's something going on inside. And so my point was, regardless of the type of problem, youth, children, adolescents, their behavior happens in a context, and that context is a family. So that looking at the family becomes a critical component to helping them. They don't exist in isolation, but they also exist in a peer group and in other areas, and they exist in a community, and they exist in schools. So the context for these problems of youth are multi-systemic, and it's important to understand and to think that way to understand why FFT works in the way that it works. Families and communities are the groups of people that have had to say, we need this to stop. We need a solution. And I jokingly told you this morning that in my professional development, that I had been taught many things that were brilliant things, but I couldn't translate them into what to do. Well, you know, that's okay for us to struggle with, but these problems happen in communities. They happen to your neighbors. They happen to you. They happen to your extended family. They happen to people that can't wait for us to sort out our philosophical issues. They need solutions. And so in many places, it is communities that have tried to figure out what can we do that is the most helpful thing for the kinds of problems we've been talking about earlier. I must say that that search for a solution is way more difficult than you would think. Finding the answer is not an easy thing. It's very, very hard. The good news is there are some different things that help. For a moment, let me be a little philosophical. Let us think, or I want to suggest to you, that in our profession, I want to ask you to think about why it is and what it is that we use as the basis of why we do what we do. And there are many things. For example, things have to make sense. And in our profession, you know, once you have your degree and once you have your education and you go to practice, you can do what you'd like. And the likelihood is that you will do things that make sense to you as a person. If it's similar to your background, in fact, I hear frequently practitioners say, I'm trying to help a family because it was good for me and it makes sense to me. Well, that's nice. That's a good thing to do. It's got to make sense to you. But sometimes the things that make sense to us are not always the things that are effective for anyone other than us. So it is not usually a good source of information. The other place that we and students, if there are students, how many students are here? Do we have students in the? Okay, I thought there were some students that were here, but when you were a student or if you're a student, one of the things that we do as professors is that we tell them what they should do. And frequently, my students, if I say, why do you want to do that with a client? They will say, because my supervisor told me I should. Or they will say, because I read it in a book, and that has to be true. Or they will say, I saw someone like Tom Sexton give a workshop and he said we were supposed to. So it must be true. We call that expert validity, meaning it's what tradition and it is what someone important has told us. The third thing that we frequently do as the source of why we work with clients in a particular way, and this is a funny word, zeitgeist, but it's like what is big and hot and important today. Now, in the United States, currently, the most big hot topic is trauma treatment. And I'm not sure if trauma treatment has become big here, but it is our new big thing, trauma treatment. 5 years ago, it was something else. 5 years before that, it was something else. You know, when I was being trained, I got trained as an Ericksonian hypnotist because that was what was big. And so a lot of times we do things because it is the treatment of the week or the treatment of the year. And the Other reason people frequently do what we do with clients is because of what we're frequently told in our training. Do what you're comfortable with. Do what fits you. It's nice, good to do what fits you. Not sure that it's always good for the client, but if it's comfortable for you, that's a good beginning. But that's another reason. What is interesting about these is that science as a reason for what we do is relatively new. That is not a thing that has been around as the source of why we do what we do for very long. And in fact, there's huge controversy about science and whether science fits. I have to say that it's sort of interesting to me that we're struggling over scientific information and whether we should follow it, when in most other things we do. If you know from science that eating certain foods causes cancer, you're probably not going to eat them. You're not going to say, yeah, but does it taste good? Instead, do I like it? You're still going to probably follow the science. But when it comes to our work, that can be a little different. When it comes to our work, we frequently don't follow science, and surprisingly, that's relatively new. Now, here's what we typically do, and again, maybe similar here in Korea, maybe not. But for example, when we want to prevent drug problems and behavioral problems, I don't know if you are familiar with this program that we had in the United States. It was called DARE. I forget what the 4 letters stand for. But basically, they would send a police officer into the school to show the kids all the terrible drugs, and they would have a board, and they would show them. They would tell them the terrible things that would happen to them. They would give them fancy pencils, nice little cases, and they would drive cars that said DARE, and they would try to have a big impact. Millions and millions of dollars went into DARE for a decade. It didn't work at all. Not a bit. Not even a little bit. And in fact, what was happening was that the kids were looking at these drugs and going, now I want to go find that one. I want to see what that one's about. In drug abuse, we treat youth with drug problems the way we treat adults. We treat it as a disease. And if you're in the substance abuse treatment field, you know that most treatment programs are based upon the AA, or the abstinence models of treatment, and they look at substance abuse, whether it's alcohol or drugs, as a lifelong disease that you never get over. Well, what's interesting is that when you treat it as a disease, when you treat it as an individual problem with adolescents, it just doesn't work. And it doesn't work in large part because adolescents need to learn to make their own decisions. And the treatment is telling them that they can't, that they have to look to something else to make their decisions. So we're having trouble figuring out what to do with drug problems. With other problems, we do a variety of things. Some helpful, some semi-helpful, and some not helpful at all. For example, one of the things that in America we do is a program called Scared Straight. Now, if you don't know what, we even have a reality show. By the way, we have a reality show about everything. But we have a reality show about Scared Straight. Basically what happens is that you send kids someplace and you're really mean to them and scare them to death. Or you take them to a prison and you wander them around in prison and say, see, if you don't straighten up, you're going to be just like these guys in this prison. I did that program, not as a delinquent, but as a counselor. And in doing that program, I thought that was important to tell you. And in doing that program, what we discovered was this. I worked in a program where we took youth to the Missouri State Penitentiary. They let us wander around inside the jail, and it is a scary, scary, scary place. I still drive the speed limit. I don't break any laws. It scared me straight. However, the youth, they weren't scared. In fact, they came away saying, now I know what it's like, I can handle it. Didn't work so well. Scared straight doesn't work. And I have to say, and I mean this with all due respect for those of you in the audience that are brilliant individual therapists. So please understand what I'm about to say is with all due respect. In general, there is very little evidence that individual therapy with an adolescent works from a scientific perspective. That does not mean that what you're doing isn't helpful. That means on the whole, if you were going to do something, it's not particularly effective. We've learned a lot of lessons from science that are enormously helpful. They're very helpful. And they may not, it may not be that you're struggling with these, but we are in America. For example, what happens when you have a very disruptive youth in America is that we're quick to send them away from their home and their community to a residential treatment facility. We're very quick to send them to a very nice looking jail where they supposedly get treatment. I'm joking there because they're not nice places, and they send them away from home. In other countries, for example, a number of years ago in the Netherlands, when you would send a youth away, it would not be for a week or a month. It would be for many years. Here's the bad news. It's good for the people that are struggling. It's not so good for the youth. It labels them for the rest of their life. And guess what? Someday they have to come home. And so we're working with them outside. And the research says this: if you want to be successful, don't take them out of the community and don't take them out of the family. Leave them in the context that has something to do with the struggles that they have, which is what we discussed earlier before the break. Secondly, we learned from the science that you need to look beyond one factor. You need to look at multiple factors. We've learned, as I said in my introduction, that it's really important to start to think about engagement and motivation as part of treatment, not the responsibility of the client. We've learned to individualize treatment, not put kids and families into a curriculum of a treatment, but to try to have treatment that wraps around them, so to speak. And the science, the biggest lesson from the science, is that these complicated problems require systematic approaches. And from the science, we also know that these complicated problems require largely family-based approaches. Now, it says 2, but there are actually 3 initiatives that are helping us integrate science into practice. The first of those is a program that started 15 years ago in the United States. And in fact, the Blueprint program is relatively well known, and it's a brilliant label, right? A blueprint for change. It's a really brilliant thing. And a blueprint for help. And now, over the last 15 years, the Blueprint program has made one of the biggest impacts on how we work with youth that has ever happened in the last 50 years. It has made a huge, huge impact. Secondly, we've had our Surgeon General, which is the top physician in our country, decided that youth violence was a public health problem. And the Surgeon General came out with recommendations. And thirdly, and I'm not sure if you're having this happen in this country, there are what are called treatment guidelines that are being developed all around the world. These are guidelines very much like those that a physician follows. And basically, they're scientific approaches that are turned into guidelines for a practitioner to follow. Quite honestly, this is what happens when you go to your physician with a physical problem. They don't just do what they want, they follow a protocol and a guideline that's based on science. I happen to be on the treatment guideline committee for the American Psychological Association. And for some people, our work is seen as the future. For other people, our work is seen as the devil that will ruin psychotherapy forever. And therein lies the controversy. What's different about these initiatives from other ways of working is that they use science as the foundation of what to do. Now, what's really nice about what you and I do is this. I didn't become a psychologist and a family therapist to follow a step-by-step approach with my clients. I like being creative. I like being artful. I do it because I enjoy the challenge. And my guess is that if those of you in the audience decide to become a family and let me demonstrate, you will really put me up to the test of a challenge and make me be creative. I'm guaranteed of that. I enjoy that. That's why I do the work that I do. That's why I don't make widgets in a factory. I do this because I like the creativity. I think that working with families and kids is harder than rocket science. And it is harder than rocket science because at least in rocket science you know where you're going. And at least in rocket science you know the physics and the parameters and the engineering principles. With our work, many of those things we don't have a clue about yet. So despite the fact that our science may be relatively new, it is surprisingly strong and robust and powerful. And I have to say, particularly in the family treatment area, way more so than in many other areas. For some reason, family therapies, family psychology approaches, whoever they're done by, have some of the strongest science in the psychological field in what's called intervention science, meaning the science of what works and how to make things work. Now, the Blueprint Initiative was interesting, and I'll do these relatively quickly, but they're interesting to think about. The Blueprint Initiative had a very simple goal, very simple. They wanted to know what worked. Seems like a brilliant idea. And they started off with 5 criteria. I know 3 of them because they're the 3 they ended up with. Does it work? Does it work with diverse people? And can it be taught to someone other than the person that made it up? Meaning, can someone other than myself do functional family therapy? Can we move it into communities with different ethnicities and cultures and types of families? And does it basically produce good outcomes? That's good news. And they worked really hard. And they also looked at cost effectiveness. Was it worth putting the money into? There's a lot of things that we could do that cost so much money that they're not reasonable choices. So this is what they were interested in. And they looked at, and this number is now about 1,500 published programs. They've looked across everything that's been published. And you already know the answer because you've got the slides on in front of you, but the answer is there's some good news. There are programs for preventing and treating these enormously difficult problems that I discussed earlier. So there are programs for those difficult problems that work. There are 10 of them. Now, it's not so hard to do the math. That doesn't even keep us at 10%. That keeps us below 10% of the programs that are published have any evidence that they work. Now that doesn't mean that some of them don't work. It means that some of them don't work and some of them we haven't tested. That's what that means. And I have to say, as a social scientist that does intervention in research, it is hard. It's really difficult. And it's expensive. So it's no surprise that everything hasn't been tested. Now, the bad news is most things don't work. That's a little bit scary because we're doing a lot of things and we're trying hard, and this is not about good intentions of the intervener. This is about whether something works, not about whether we're good people and we're trying hard. And so 10 of 1,500 is not so many. Now, here's some things that don't work. I already told you, our drug abuse prevention thing. Under Bill Clinton, we decided that what we would do, since I don't know what the gun laws are here, but in the United States, actually when our friends come from the Netherlands to visit, one of the stops on our way is we show them the university, we show them Bloomington and our wonderful farmers market, and we take them to Walmart and we show them that you can buy a gun and that Walmart has got a whole wall of guns. It's, I hope, uniquely American. But quite honestly, if you wanted to be an elected official, you cannot, no matter what, all the problems, you could never suggest taking guns away from Americans. We're just not going to do it. So we decided, well, if you can't take them away, maybe you can buy them back, right? Guess what? We bought all sorts of guns back and it didn't help because they used the money to buy better guns. I don't know if you've ever heard of boot camps, but these are another thing we tried to do with kids, and the idea was you take delinquent kids and you put them together in a group and you put them in a uniform and you send them to a camp. And in Nevada, where I worked when I was at Las Vegas at the university, they used to take kids and put them in uniforms and send them out to the desert, and they would live there for many months, and they'd have to do, just like the Army, push-ups, and they'd have to run, and you know, we just put them through boot camp training. It doesn't work. But if you think a little bit about it, it's not so hard to figure out why. Sounds to me like an organized, sanctioned gang. Because what happens is they come back very strong, very organized, and they come back really mad. Really bad combination. It doesn't work always, on the whole, to have peers counsel people, and it doesn't work on the whole just to give kids a job, and it doesn't work to put those little electronic bracelets on their ankles. And I don't know if you do that in the justice system here, but it is enormously popular in the United States. In fact, in my little town of Bloomington, Indiana, the chief juvenile probation officer is a good colleague of mine, and he loves these things. He just loves them. But there's a reason he loves them, because like, he can go on his iPhone and he can put in a number and he can see on a map where every kid is. He thinks it is so cool. But here's the bad news. Eventually, those have to come off. And then what do? They've been waiting that whole time to go have a bunch of fun that will get them in a bunch of trouble, and they come off. Or what happens is you get a very assertive person, as Ostrid had a case once, where the kid just cuts it off their ankle. It's not so hard. They just cut it off, you know. But guess what? Then they send them to prison. So these things are nice. They will keep people from getting in trouble in the short run, but not in the long run. And deep in my heart, this one really hurts me because I did this for 3 years. And I have to say it's hard for me to say this because I really want it to work. I really do. And these are what we call wilderness education programs, or as I call them, hoods in the woods. This is taking delinquent kids from the cities, taking them out into the wilderness, and you take them totally out of their context. And I did this. My job was to take kids out for 28 days, a group of 10. We would never see anybody. We would never walk on a road. We lived in the woods. We lived in caves. And we changed those kids. We changed them. And then you know what the problem is? They went home. And it was not very long after they went home that all the changes that they went through went away. Because we had missed a fundamental thing, which is behavior is connected to family relationships, not just to individuals. It didn't work, and it tends not to work. General counseling, as I said, with all due respect, and please, with all due respect, in general, on the whole, not so effective. And it isn't because it's not effective. It's more that we don't know what it is. I mean, it's hard to know what, individual counseling is. What is that? So it's hard to know what it is. In case mentoring doesn't always work. There are some things that just make it worse. I don't know what happens here, but in the United States, if we're really unhappy with a kid, whether they're 10, 12, 11, 14, we just decide they're an adult, and we send them to adult court. Clearly that doesn't work. It doesn't work scared straight. It doesn't work to try to shock them. A lot of mentoring programs produce really bad outcomes. But the good news is that there's a whole plethora of things that do work, and they do work very well. I'm not going to go through each of these, but I do want to point out a couple things to you. Notice FFT, multi-systemic therapy. Notice the nurse home visitation program and the treatment foster care program. Each one of those are family-based interventions. Those interventions work. So when I said earlier that family-based interventions work, it is more than my opinion and my heart. It is also the current science. Now, there's one more thing the science has told us. The science has told us you can have a wonderful way of working, but if you don't implement it in a community in a good way, it just does not help. So learning what's enough training, learning how long to train, learning how to support and help has been and is a really important thing. Here's an example, and let me show you this interesting graph. The largest FFT study ever done was done and published by myself and Charles Turner in 2010. It was a study that we did in the state of Washington in the United States. It's a study of almost 1,000 families and kids. It is a study not of super therapists, but of regular therapists. We trained them, and then we sent them off to do FFT in the real world. And what we discovered is this. There are 3 lines that you can see. Let's start with the blue one on the bottom. And we tracked whether or not the youth got in trouble at all, for any reason, a year later. Now that means that anything, cross the street the wrong way, get thrown out of school, anything, small or not, we tracked it. Notice at 6 months, about 6% of them had gotten in trouble. Notice at 12 months, it was about 11% of the 1,000, the number in this group that got in trouble. And at 18 months, a year and a half after FFT ended, we're talking 12 sessions, 16% of them had been in trouble for something. That means 16 out of 100 got in trouble. That is pretty darn good, given that the traditional outcomes are that about 75% of the kids in treatment fail. So this is a pretty dramatic outcome. And in fact, we reduced violent crime by 50%, 50, cut it in half. We reduced the most serious crimes by about 40%. That's pretty dramatic. And we did a cost analysis. Every single dollar that went to FFT, training, supervision, or anything, produced a return of $14.67. I wish I got that much return on my retirement fund. And if I did, I'd still be here. That's not true. Now, let's compare that, because those are pretty good outcomes. Let's compare that to 2 others. The yellow line in the middle is no FFT at all. In fact, no treatment. It is only having a probation officer do probation, which means they check on you occasionally. Notice, kind of similar at 6 months, although that's statistically significant, and at the end, a pretty big difference, but not bad. Probation works. Here is the implementation question. You know what the red line is? FFT done poorly. FFT implemented poorly, and FFT done poorly by the therapist. It turns out that it's worse than nothing, much less that it's worse than good FFT. Now my point here is to say this. There is no magic in these treatments. These treatments are only as good as you can implement them with a family. They are only as good as they can be implemented by the community. This is not just an FFT finding. This is a finding that's similar across all of the evidence-based programs. So, not only do we have science about what works, but we have science about how important it is to do it well. This is not in your slides, so don't look for it. This just is that of all the science we have currently, the family-based interventions, family therapy interventions work best, but not all of them work best. So let's take a few minutes and talk a bit about the evidence-based treatments for kids. Now, an evidence-based treatment, so start with just what it means. I mean, it's not a scary thing. All an evidence-based treatment is an intervention that has a high probability of working. There's no guarantee on any of these. None. It just has the probability that when done well, it will work. And just as in education, medicine, and other places, it puts science at the center of family and couple therapies. And science is becoming, as I said, a giant part of medicine and everything else. Now here's the difficulty. Seems to make good sense, right? Seems to make great sense. It's not very well accepted by folks like you and me, at least not in the United States. It's not accepted well at all. And in fact, many times when we go to communities to implement FFT, it is not the kids that are our biggest problem. It is not the families that are our biggest problem. It is the therapists. They don't want to be told what to do. They don't want to be told to do something new. They don't want to be suggested that they should learn a new practice. And in fact, honestly, I've given many talks about this around the world, and a frequent question I get is a wonderfully experienced therapist will sometimes, and during the day, raise their hand, and they will say, does this mean I have to learn something new? My answer is, when I get over my shock, my answer is yeah. Because as professionals, we should always be learning new things. So it is not well understood. So the public sometimes has problems, but the professional community with programs like FFT gets very stuck on some myths that get in the way of adopting and learning something new. And those are myths that I'd like to take just a couple minutes to go through. Now, I want to say that I think actually that one of the most useful parts of an evidence-based treatment is where it puts the emphasis and the attention. It puts the attention on the intervention, not on the desire and the will and the comfort of the therapist. It means that for all of us, we may have to learn things we're not comfortable with to be good with lots of families. When I was trained, I was taught, pick a therapy you're comfortable with. Do it. Well, when we train people in FFT, you know what we suggest? If you're comfortable at something, great. Do something else so you get comfortable at that too, so that you can do more than one thing. Don't rely on your strength, but play to your weakness so that you get better. And so it moves the program away from the will of the therapist to what's reliable and what's consistent and what works. So let's look at some of the myths. I'm not sure if you've read the literature, but if you read some of the literature by my colleague Bruce Wampold and other people, there's this big idea that all psychological interventions are exactly the same. They really work all the same at the end of the day. There's really no difference. We call that the dodo bird effect. That comes from the book and about Alice in Wonderland, which is the dodo bird says at the end of the day, we're all good, we all win, and we all deserve prizes. And in fact, I'll tell you that 12 years ago, I wrote a book about the evidence of psychotherapy. And in that book, I suggested that the dodo bird phenomena was true. I've changed my mind. That's the good news about being a professor. We're supposed to change our mind all the time. So that's the good news. But I've changed my mind. And I would say to you that that is a myth. Everything is not the same. In fact, for the first time ever, there's been a meta-analysis that compared evidence-based treatments to theoretically based and non-specific treatments, in family-based treatments. It's done by Baker, published in 2012. If you're interested in meta-analyses, it's a really dramatic thing. And they find that, lo and behold, true, evidence-based treatments not only should work better, but they do work better at a fairly significant degree. So that is a myth that everything is the same. Now, that may make good sense, right? I work in a faculty of 12 at Indiana University. A faculty of 12 very smart people. And our program is rated, I think, 6th in the country at this point. 7th, 8th, 6th, I don't know, it depends on which group you look at. And I am the only person of the 12 that suggests that this is a myth. Everyone else believes everything is the same despite the science. So while the science is clear, it is not something that's well accepted yet. Secondly, the other myth is this. Research is irrelevant, it's biased, and it really doesn't have anything to do with practice. That's a common myth. For example, many people say, well, in a research study, you pick the best clients. You always pick the clients that aren't complicated. You always pick the clients with one single problem, not the clients that have complicated problems. No wonder they work, these research studies. And they say, you know, and maybe you've heard people say this, if you keep reading, you're going to find one study that tells you one thing, another study that tells you another thing, and another one that tells you a third thing, and there's no consistency. Well, that's not really true. Maybe 25 years ago, most of our science was done on college students. And the reason is because you could give them credit to participate in your study. Happens all the time, right? And when I was an undergraduate, I was in a number of studies. In fact, I got a really good grade in my basic psych class because I went to a lot of studies. But I have to tell you, I know what I did. I tried to figure out what they wanted. I was interested because I wanted to know what their hypothesis was, and I'd go in and I'd make stuff up just in order to get my credit and mess around with them. So it is true that if science is based on the psychology of college students, it doesn't help us very much. But that is not where the evidence comes from today. Studies have to be done in real-life settings to get funded. Studies have to be done in real-life settings to be published. There are few journals that would allow studies of any kind of psychotherapy that wasn't with real people in real communities anymore. It is just not true that the evidence is done with irrelevant clients. This is a really big one, and I happen to agree. And the third myth is this: there is no substitute for clinical judgment. Experience, those trump, or they're more important than science every day. Now, basically what that means is that if I believe it, it has to be true. And if somebody else says this, or the science says it's true, then it can't be because it doesn't fit with what I believe. Well, if you've taken a social psychology, you know that that's called the fundamental attributional error. And the fundamental attributional error is simple. Can't be us, it's got to be somebody else. Few of us look at the cause as ourselves. Most of us look at the cause outside. And there's nothing bad about that. That's normal. And so this business of experience, it is true. If you are really experienced, you've had thousands of hours of therapy experience working with clients. You're good at what you do. I am better at FFT because I've done it a lot. However, if the practice you're doing doesn't have a scientific foundation, your experience is good experience and it's valuable, but it's not going to overcome whether or not it's helpful. And that's largely because of sampling error. We only know what we see, and we only see what we know. And that's a funny combination. We don't see outside of our own lenses. And so this business of experience is a gigantic problem and myth. Now, fourth is one that gets used in the US a lot. If it's legal, I can do it. So don't be telling me to do something else. As long as I don't break the law, why can't I do it? Well, let me give you an example. About 8 years ago in Utah, Utah is a state in the West in the United States, there were two women that had a very wonderful, thriving private practice, and they did what was called rebirthing therapy. You know what that means is that they believed that the kids with problems, the problems was because of trauma that occurred when they were born. So what they would do is that they would re-experience the birth trauma so that they could get through it differently. So what they would do is they would put the youth on the floor and pile blankets and pillows and everything on top of them, and the mother would usually, it was always the mother, of course, right? Not the father, but the mother. And the mother would sit on top of them, and they would try to get out, and the mother would keep them in, and they would go through this battle of getting out and staying in, and getting out and staying in. Well, supposedly it helped until one day a kid smothered underneath the pile of blankets and pillows and died. Guess what? It was legal then. It was okay. It was a common practice. But it resulted in a very bad outcome. We have the same thing in the United States today with gay and homosexual couples and youth. And while that's extraordinarily controversial, the state of California recently passed a law that said that counseling approaches to do sexual reorientation therapy were illegal. Because it's value-based. I mean, whatever you believe about same-sex couples, whatever you believe about homosexuality isn't the issue. The issue is that the question is it helpful? And it's legal in many places. We can't stop it. So people say, yes, then it's a good thing to do. A myth. How can it fit diverse clients? And how can it fit clients that are unique? How can any protocol fit the diversity of families that we see? Now this, in the United States, the issue of cultural and cultural competence, multicultural competence is very strong in the profession. We're a country of many, many cultures. We're a country of many, many ethnicities. And multiculturalism is appropriately a very big thing. But here is one of the myths that happens when it comes to evidence-based practices. That works fine for white people. That works fine for the majority culture. but does it work for people that are different and diverse? And what they would basically say is that the only way you can have a treatment that works is if you let people from that culture develop it. Now, I would say that that's really true. How can I, and I'll have a difficult time tomorrow if you come up with a family, how can I know what it's like to be Korean? Because if you didn't notice, I'm not. I mean, I don't speak Korean, but I'm clearly not. I don't know what it's like to live in the culture. I don't. The question is, does that mean you can't do good therapy? Well, if you do therapy by a stepwise approach, meaning by where you don't think about the client, it would be difficult. And many, many, many Western psychological therapies don't work outside of their culture. However, that's not a universal issue. That's not a universal finding. Our FFT research has found something fascinating. We have been unable to find a difference in the effectiveness of FFT in different cultures, ethnicities, and races. We now have 3 studies where we have tried to look at the difference between white majority Americans, Haitian Americans that speak 0 English, Hispanic Americans, and African American Americans. We have been able to find 0 differences in the outcomes. It is not the client diversity, it is the therapist's ability to adjust to the client. So this is a myth, while very powerful, also today, at this point, seems like it's not upheld by the science. Let me give you a couple examples to try to bring this home. I have, unfortunately, very serious back problems. I've had back surgery. By the time the day is over, since I'm standing, I will be in tremendous pain. I'll want to go for a walk this afternoon. I'll have trouble. When I got off the plane yesterday, I could barely move. It's just it's a physical problem. I've had fusion surgery on my back. It's been very serious. Now, the question with my back problem is this. So who do I go to? I went to some people that said, hey, I can fix everything. Trust me. No. Didn't fit with me. Who am I going to pick to do surgery on my spinal cord? I mean, think about it. You know what the mistake means? The mistake means I'm giving this workshop in a wheelchair. It is a very serious decision. And I have to say to you, for me, that decision was made based upon who had good outcomes. My question to my surgeon was, how many times have you done this surgery? Do you know what it is? Do you have a protocol? And how many times have you been successful at this surgery? The good news is it took me 3 of them, but I finally found one that could answer those 3 questions. And that's who I went with. And that's why I'm walking. Painful or not, my life is way better. We have an interesting political debate. Maybe you have it here, although I understand that green energy here is very popular and you're a real leader in the green energy field here. I understand that you're building an entire green city for a capital, and there's some miraculous things going on here. But we have a debate, and if you watch the American presidential debate, you will see one of the things they fight over is whether or not climate change is real. I don't know about you, but the weather's doing some strange things in the US. It's, pretty soon, Indiana, we're going to be a tropical paradise. Because it doesn't rain as much, it's warmer, it's hotter, things are changing, and we have people in the political scene that say it's not true. It's all made up. It's a liberal conspiracy. It's a plot. What are you going to believe? The science? Or what are you going to believe? The politics? What if you had a heart problem and you suddenly found yourself with a cardiac issue? Where are you going to go? You're going to trust yourself to somebody that uses science and has good outcomes. You're not going to pick the person that your brother-in-law is a friend with. You're not going to pick somebody that is just easy to get to. If you're going to die, you're going to pick the best that you've got. When you go to buy a car, what do? My father, who's now 90 years old, he will only buy one kind of car, period. You know what? He won't buy a Japanese car because he fought in the Pacific in World War II. And quite honestly, at 90 years old, for him, things are a little jumbled right now, but for him, that is a thing he just won't do. It doesn't matter if it's a better car, he just won't do it. And, we have a thing in America that you can go to if you want to buy a car called Carfax. You can look up on the web and you can get the truth, about how reliable it is. So which one are you going to do? Are you going to follow what my dad says, or are you going to follow the science? And what if you need somebody to build you a new house? Another example. You know what? Don't pick your friend who thinks they could do it and has always wanted to build a house. Don't be the guinea pig. You're going to look for somebody that builds houses that you like. Here's the point. We can debate about these scientific things all day long, but when you turn them into practical questions, who will you take your child to when they're having trouble? Who will you take your child to when they are so stressed about getting into the next school that they don't sleep, that they don't eat, that they lose contact with their peers, and that you worry whether or not they will be a statistic and be a suicide like you struggle with in this country with a lot of youth? Who are you going to take them to? You're going to take them to the best. And what is the best? The best is not who you're familiar with. The best is the science. So when it comes down to it, in practical questions, this debate about evidence is kind of silly. But we have it. And again, I don't know how much you have it, but I would say to you that evidence-based practices are here to stay. They are not bad, and they will help. And part of the reason is this, because they're all they care about. Evidence-based practices have a core philosophy. Everybody has the right to the most effective treatment that exists. I believe in that philosophy. I think that the clients that come to us we have a responsibility to give them what works. That's why I do functional family therapy. Meaning, if the science isn't there, you don't do it. And the science can also be used as a way to make sure that it's done correctly in the community setting. Earlier I said to you that I will make you a bet, that I'll bet to you that in the system I'm going to talk about tomorrow afternoon, it will be common to practice in 5 years. Maybe that'll be 10. There's a lot of you, I don't want to have to buy lunch for everybody. So I need to hedge my bets a little bit. But I have to say that evidence-based treatments are useful to do, but they have to be practiced in an evidence-based way. It's not good enough to have an evidence-based treatment. You have to practice them in an evidence-based way. And so it is accountability. Accountability based upon the science, and accountability based upon using evidence that you gather every session to make sure that you're on track. Two things make an evidence-based program. First of all, you can demonstrate a good outcome. That's not a very high bar. That's not a very big standard. Shouldn't we have to demonstrate that what we do works? Now, when I was in school, here was the argument. The argument was this. Well, it may not work today, and it may not work tomorrow. And in fact, it may take 10 years before the seeds that I have planted in this family finally grow. But I am convinced that at some point in their life, whatever we've done will sprout and grow and help them. Right? Maybe you've heard that argument. I used to say it. It would be nice. I don't know if we can get away with that morally, ethically, and professionally anymore. So you've got to be able to demonstrate, and then secondly, evidence-based programs have to monitor themselves along the way to show that you're on target. Remember my slide about FFT? I didn't show you a different treatment, I showed you my own treatment. And I said to you that if it's not done well, it doesn't work. Now that means that the program has to have a way to monitor fidelity along the way for it to work. So what's been missed in this argument? What's been missed is, you know what? It only helps the consumer. It's only good for the client. I'm not sure why we struggle with these myths. I think they're our own struggle, not the clients. And the clients come to us and they don't really care. They want a single thing. They want to be helped. And they want to be helped. And to do that, here's what it takes. It doesn't help to do something broad and general and non-specific. Counseling. I don't even know what that is. I teach it, but I have to say, when you call it counseling or when you call it individual therapy, it's hard to know what it is. When you call it FFT, you know exactly what it is. Meaning you can measure it, you can monitor it, and you can see if someone's really doing it. How many brands of individual therapy are there? There are as many brands as there are people doing it. How many brands of family therapy are there? There are as many brands as someone doing them. When I go and Astrid goes to a place and we go to implement FFT, our first question is always, what do you do currently? And you know what they tell us? I do family therapy. We go, good, what kind? They say family therapy. We go, great, what kind? They say family therapy. And we say, what kind of family therapy? And they go, family therapy. How can you do something that you can't describe? How can you be effective with something you can't describe? And so, to be effective, treatments have to be specific enough and have enough detail that you have to be able to know what you're doing, when you're doing it, where you're going, and why you're going there. Without that, we've fallen into the same myth that we have in other kinds of treatments. So it is just nothing other than this. It's an intervention that's described well. It's an intervention that has science, that can be transported, and that can be applicable across different kinds of clients. And don't worry, you'll read this if you want to. It has principles. Every evidence-based treatment has a theory or a set of principles behind it. In a little while, I'm going to talk to you about what I call the lens of FFT. That lens is critical. If you see things in an FFT way, you can do them. Secondly, all that principle has to do is it has to be practical. It has to help you understand how people work. Usually that's in a manual. And I have to tell you, again, I don't know how this works here, but you can tell me later. But I can tell you when I get my doctoral students, these are the smartest people I know. They're way smarter than me. They're way more energetic than me. They're brilliant kids. And I say to them, what about manualized treatments? And they all go, no, 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 no. That's the devil. No manualized treatments. And I say, have you ever seen a manual for treatments? A treatment manual? They go, no, but they're bad. I have said, have you ever seen one? And the only thing that they can come up with is Ellis's A, B, C, D, E, F, G. I don't know how many letters there are, but you know the thing I mean? Yeah, antecedent, I can't even remember what they all are. But you know, everybody believes that evidence-based manuals are simplistic CBT things. And they're not. Do you know what the FFT manual is? this. It is a book. It is a book that describes principles, steps, protocols. That's it. A manual is not a simplistic thing. A manual is a complicated thing. So manuals are not necessarily bad. Evidence-based programs also, they have to be responsive to the client. If you just do a protocol and you don't care about the person sitting in front of you, that's not so helpful. You probably been trained in narrative approaches, haven't you? In your training and your workshops that you've done through here, I'm sure through KMFT that you've had a lot of narrative experience and that sort of thing. And the narrative approaches are wonderful, except they have really harmed us. Again, don't hurt me. I'm just going to make an observation here. If you're a narrative therapist, I know you do good work. Here's what I mean. Michael White said, I have no expertise. The client's the expert. That's true. My question is, what's he doing in the room? Why be there? If you have no expertise, then you don't need to be there. Let them be there with themselves and they'll figure it out. Guess what? You have to have the client's input, but you also have to have something else. You have to have this evidence-based model that gets translated to the client by the therapist. And so, at the end of the day, you know who sits in the room? Two experts. The therapist is the expert on the treatment model. The client is the expert on their life. And together, collaboratively in alliance, they each bring something special to the table, and it only works with both. So these treatment programs, great as they are, if they do not have a way to work with a client, they just don't work. And that means that despite the fact that they are protocols and they have manuals, evidence-based treatments require you to be an artist. A creative, artful magician in the room. The best FFT therapist is a magician. They're artful, they're creative. Guess what? They work around and through the protocol and they deliver it in a way different to every family than they did to the other. Same model, done differently. So it has to be both for them to work. And these programs have training programs, and they have quality improvement systems, and they have evaluation procedures, and they get disseminated in certain ways. It is not just a manual, but the current day evidence-based practices come with a big package to ensure that, as I said, they're implemented effectively. The family-based approaches are particularly powerful evidence-based approaches. This may or may not be in your slide, so if it isn't, I forget which one I added. But here, from our list earlier, are 5 of them. FFT and MST, therapeutic foster care. I would add one more. Howard Little, my colleague in Miami, with multi-dimensional family therapy. It's having very good outcomes with substance-using kids. The family-based interventions are good, and these are the current ones, and they are cost-effective, and they work. And they work better than structural family therapy, strategic family therapy, whatever that is. Bowenian family, multi-generational family therapy. Those don't have evidence. Do they work? Hard to know, but there's little evidence. And in fact, I would say to you, I've met and talked with Sal Minuchin a number of times, and I've actually asked him about this, and he laughs. And he says, I don't even know why people keep doing structural therapy like I did in 1972. I wouldn't do it that way. And so, certain models change, and certain models work, and certain models don't. And the most effective ones are the family-based interventions, of which FFT is.